So first, our next two presenters who will be speaking on cardiac issues in pregnancy. First, we will have Dr. Estelle Jean. Dr. Jean is a board-certified cardiologist at the MedStar Health. She treats a full spectrum of cardiac disorders with a special interest in women's heart health, maternal health, and addressing healthcare disparities. Dr. Jean also collaborates closely with obstetricians to manage cardiovascular disease, high blood pressure, and preeclampsia during pregnancy. She is passionate about community-based medicine and improving health through education. She serves on the MedStar Montgomery Board of Directors, the MedStar Health Women's Heart Program Leadership Council, and is the Health Equity Lead at MedStar Montgomery. Additionally, she is board certified in echocardiography and serves as the director of the vascular lab for MedStar Health Cardiology Associates. Recently, she was nominated for the 2024 American Heart Association Women of Impact in the Greater Washington region. Dr. Jean received her medical degree from Rutgers, New Jersey Medical School, and followed a residency program for Harvard's Massachusetts General Hospital. Subsequently, she completed her cardiology training at MedStar Georgetown University Hospital. Second, we will have Marilyn Berchie-Gialamas. Dr. Berchie is a family nurse practitioner specializing in maternal child health, nurse educator, and researcher. She is the healthcare director for Trinity Wellness and the postpartum nurse practitioner for Baltimore Healthy Start. Her research projects include being co-investigator of the HRSA-funded Maternal Health Research Center at Morgan State University and the primary investigator in a research project entitled Racial Disparities in Maternal Child Health and the Role of Doulas in Reducing Disparities. So first, please welcome Dr. Jean, and then we will get questions after both speak. Thank you so much.
Good afternoon, everyone. Thank you for having me on today to discuss a topic that's very near and dear to my heart, and it's going to focus on preventing future cardiovascular disease by managing adverse pregnancy outcomes. The main learning objectives today will revolve around understanding the important role of a multidisciplinary cardiobstetrics team to improve maternal health outcomes and understand the relationship between adverse pregnancy outcomes and future cardiovascular risk, as well as the important role of both preconception counseling as well as postpartum care. But I do want to first start with a patient that I recently saw, which really highlights the importance for cardiobstetrics. So she's a 41-year-old Black female, and she was sent to my office for an evaluation after she had an ER visit for chest pain. And her blood pressure initially was elevated at 177 over 106, and she was not on any blood pressure medication. And her EKG was suggestive of a prior heart attack. And when I dug more in terms of her pregnancy history, she stated that she had preeclampsia with her first pregnancy at the age of 20. And then subsequent with her second and third pregnancies, she said she was told that she had eclampsia, but no history of seizures. So I suspect more of a preeclampsia with severe features. And the fourth pregnancy resulted in a C-section sort of at 37 weeks, which did not lead to a recurrent in preeclampsia. And, thankfully in cardiology, we too have sort of thought more about a woman's health in terms of across the lifespan. And we do know that there are critical vulnerable periods of cardiovascular risk during that time period. And as been mentioned before, during our early years, there are clues that we can get, such as early menstrual cycle or premenstrual syndrome, but definitely the reproductive years, as we're learning from more and more research, gives us important clues in terms of a woman's future risk for cardiovascular disease. And why is this important? Why am I here talking about this? Well, we know that cardiovascular disease is the leading cause of pregnancy-related deaths in the US. And there's several reasons for which many were discussed this morning in terms of the increasing morbidity and mortality, but advanced maternal age is important. Pre-existing comorbid conditions, as well as a growing number of women who are born with pre-existing heart condition, congenital heart disease, who are surviving, thankfully, into childbearing age. And so what do we mean when we're sort of talking about cardiovascular disease? Well, it includes having a history of high blood pressure during a pregnancy, blood clots, congenital heart disease, Coronary artery disease, because that too is on the rise in younger individuals. So we're seeing women with pre-established, pre-existing coronary artery disease, as well as preeclampsia or eclampsia, any valve heart conditions, which is considered heart disease. So, for women with heart murmurs, if there's significant valve issues, that also is considered, and high cholesterol or other vascular disease, heart failure, and lastly, abnormal heart rhythms or arrhythmia. So that's sort of the full spectrums in terms of cardiovascular disease. Now, if you break down based on the most recent data published from the CDC, other cardiovascular disease is leading, followed by cardiomyopathy or weakening of the heart muscle, resulting in congestive heart failure, hypertensive disorders of pregnancy, which I will go into more detail, as well as strokes. And that comprises about a third of the maternal deaths. And this is also consistent with the most recent Maternal Mortality Review Committee data. Again, similar numbers, but comprising about a third of the maternal deaths. And an important number to sort of distinction in the cause is age. If you look at 40 and above, in the most recent 2021 data, 40 and above versus 25 and under, had almost a seven-fold increased risk, 7 times increased risk. And so as women and birthing individuals choose to have children later in life, there are important health complications that can happen purely because of age. And of course, we know the impact of race, that Black women, non-Hispanic Black women are 2.6 times more likely to die. And so how many of you have heard of cardiobstetrics as sort of an entity within the field of cardiology? Okay. Awesome. I see a few hands, but in cardiology, we recognize that this is an important collaboration. We no longer can work in silos and focus on our respective discipline, because this really is a critical time period in women's health, and the numbers are increasing across all age groups. And so the focus would be a full team that helps to manage the birthing individual throughout their pregnancy, and sort of different touch points, be it the preconception counseling, monitoring during pregnancy, and of course, coming up with an appropriate delivery plan, and followed by the postpartum care. But I do want to focus specifically on pre-pregnancy counseling, because that, as has been mentioned already this morning, is a critical time for intervention. And unfortunately, as we know, nearly half of pregnancies are unplanned. And so it's critical that we optimize our pre-pregnancy cardiovascular health to improve outcomes in pregnant and postpartum individuals and the offspring. And that's a critical component, because it's not only the mother or the birthing individual, it's also the baby. And as highlighted in this picture here, birth into early childhood, we know that, for example, if a mother had preeclampsia, the daughter is at future risk for developing preeclampsia, but also the child develops high blood pressure earlier in life, and as well as other diseases such as obesity. And so this early childhood period is a critical time to really optimize health, so that if any unintended pregnancy happen, we have the best sort of potential outcome in helping to improve the rising rates. And so from cardiology, we recommend the Essential Life 8 lifestyle measures, and which I'll go into. And then the cycle continues in terms of the pregnancy adult, which unfortunately some individuals may develop these average pregnancy outcomes, and then the inter-pregnancy period and recurrent pregnancy, and later on in development of cardiovascular disease. And so just a brief overview, the American Heart Association Life Essentials 8 includes diet, so more of a plant-based, Mediterranean, fresh fruits and vegetables, and physical activity of at least 2.5 hours a week of moderate intensity exercise, maintain a normal blood sugar with a fasting glucose less than 100, and a healthy weight. Blood cholesterol levels should be within normal range and less than 200, and a normal blood pressure is less than 120/80, as well as not smoking and sleeping at least 7 to 9 hours at night. So these are our goals and recommendation. I know, 7 to 9. Yes, which I'm assuming most people are achieving these goals with the laughter. But it's important, if you want to optimize your cardiovascular health, mental health, all aspects of health, really aiming on increasing your sleep duration. And again, contraception counseling is a critical component of this discussion, which has been previously discussed, as well as medication adjustment. As we know, the rates of high blood pressure, for example, are on the rise. Starting from the age of 20 and above, 45% of women have some form of cardiovascular disease. And for Black women, it's 59% have some form of cardiovascular disease, for which high blood pressure is the most common. And many individuals are not seeing their providers or having important conversations about their plans. And so they are at times on medications that are absolutely contraindicated during pregnancy, such as, drugs like ACE inhibitors, lisinopril. And so if they're put in those medications and you're not having a conversation, do you plan on getting pregnant at any point? You're putting the fetus at risk. And unfortunately, less than 50% of women entering pregnancy have good heart health. And when we talk in terms of ideal health, where we're meeting all those measures, it's less than 5%. Okay. Which again, from the laughter, we're not getting adequate sleep, right? And of course, disparities in care. And this has been discussed this morning, but we know social determinants of health, access, and implicit bias are big issues that we really do need to tackle. And so again, optimal pre-pregnancy cardiovascular health, but this is broken down based on race. And if you look overall, the rates aren't that great. That's blue. So that's about 40% or optimal cardiovascular health. But for non-Hispanic Black women, individuals, birthing individuals, it's 30%. So there's a big disparities gap. Overall, the trend, we're becoming less healthy going into pregnancy. And unfortunately, that has huge implications. And why is that? Well, this study in particular looked at the impact of pre-pregnancy cardiovascular health and pregnancy outcomes. So they looked at 4 main risk factors in that data set, and it included weight, so either low weight or being overweight and obese, smoking, history, high blood pressure history, or diabetes history. And if you can look at all the different components that they looked at, maternal ICU admission, preterm birth, low birth weight, and fetal death. All of these risks increase dramatically if you had 4 risk factors. And if you just had one, your risk continues to go up. So this is really a critical part of what we do to make sure that we're getting individuals healthier in the pregnancy so we can make better and more impact in reducing the ICU admission, preterm birth, and fetal death. And so based on our most recent guidelines, it is recommended that all women with known cardiac and aortic disease who wish to embark on pregnancy require timely pre-pregnancy counseling. So where appropriate, you can consider doing an electrocardiogram or an ultrasound of the heart and echocardiogram, or a treadmill stress test for those with significant cardiovascular disease, because you do want to make sure that they can exercise to an adequate amount, which is considered at least 80% of their maximum predictive heart rate. If they can achieve that target, then they have a better chance of having a good outcome during their pregnancy. And other things that can be discussed with your healthcare team includes using CARPRED-1, which is cardiac disease in pregnancy. It's a risk tool to understand what your individual risk will be with that pregnancy. Another model that can be used is Zohara, but the most commonly used is the WHO, the World Health Organization classification. And this is where it's really important, again, to have the cardio obstetrics team. And this is just a brief overview of what it could include. So of course, obstetrics, maternal fetal medicine, and a cardiologist for patients with cardiac disease, but as well as primary care, anesthesiology, nursing, pharmacy, social work, and other subspecialties. But the key on the right is that the more complicated cardiac patients really do require a lot more team members for optimal outcomes. And so really those patients should be managed in what we call a tertiary center and a big hospital center that has all these resources to help mom and baby. And why is this? Well, there are important changes that happen from the baseline during pregnancy. And so from this chart, cardiac output, how much blood is getting pumped out of the heart, can increase as much as 40 to 50% during pregnancy. So when you're healthy, that 40 to 50% increase in blood volume can be easily well tolerated. But when you have pre-existing cardiac conditions, that extra blood volume can put a lot of strain on your heart, a lot of strain on your blood vessels and the placenta, which makes it harder to carry a delivery to term. Okay. And we have to remember pregnancy ultimately is the first stress test that many birthing individuals go through. That's the first stress test. Okay. Many times patients in their later years in life, menopause and beyond, will come and want to get their heart assessed. But that's why getting the pregnancy history is critical, because they've already gone through a stress test. Okay. And so the patient that I saw recently, early on, there's the two lines, which is the risk of what we call vascular and metabolic disease. And so during fetal and infant life, it's below disease threshold. We're not able to detect it. But when you have the stress of pregnancy, there's that upward line that shows that you can develop the disease. And she did. Her blood pressure spiked. She had preeclampsia. But unfortunately, when I talked to her, there really wasn't a lot of follow-up. She took blood pressure medications for a little bit, and for a few months, blood pressure got back to normal, not a lot of changes. The social determinants of health, being a mother, and all the other stressors happened, and there was lack of follow-up. And then so there was a subsequent pregnancy that stressed the system again. But the critical part becomes between pregnancy and middle age, because if we're not effective in our intervention, if we're not able to bring her down to the normal line beneath, she's at risk for having cardiovascular manifestation, heart attack, stroke at a much earlier age. So that's the critical time period to make sure that, if you know someone who's had preeclampsia or any adverse pregnancy outcomes, that you make sure they discuss it with their healthcare providers and get their lifestyle, their risk factors well treated to help prevent disease progression. And so what exactly are adverse pregnancy outcomes? In terms of hypertensive disorders of pregnancy, it's preeclampsia, eclampsia, gestational hypertension, chronic hypertension, and chronic hypertension with superimposed preeclampsia. The other ones are included gestational diabetes, preterm birth, and low birth weight or small for gestational weight, or small for gestational age. And about 30% of birthing individuals experience an adverse pregnancy outcome. So that's a high number. That's a high number. And so we really do need to target these patients and get them in to help improve their future cardiovascular health. And unfortunately, it does occur more frequently in Black and Asian women, and the rates are on the rise. And Black and Asian women often present with more severe clinical presentations and have worse outcomes. And as stated, there's a strong association between these adverse pregnancy outcomes and cardiovascular disease, including, and that's the key, premature. They come in earlier in life with cardiovascular disease. And based on the research, 2 out of 3 people who experience preeclampsia and other adverse pregnancy outcomes will die from heart disease. 2 out of 3. That's huge. And most don't know this. So that ends up being their biggest risk. And this is very alarming data, and why I decided to sort of get into the space and get this information out there, because so much of the care is focused on during pregnancy and the 4th trimester, that's and up to a year, but we're losing these women because we're not asking about their pregnancy history. They themselves are not aware about their risk, and they're at high risk for cardiovascular disease. And if you've had preeclampsia, this is associated with a 4 times increased risk of developing high blood pressure, especially within the first 2 years of pregnancy. So her case really highlights, in terms of the gap of care that happened, she had preeclampsia, was monitored briefly postpartum, and then the medications were discontinued. Okay. And future risk of cardiovascular morbidity, mortality is related to the severity and number of preeclampsia episodes. So this is important. Obviously, the providers here know there's severity to preeclampsia, but if you've had severe features, if it's recurrent in pregnancy, these are truly our highest risk individuals, like my patient was. And unfortunately, she didn't know. And they are at 2 times increased risk for ischemic heart disease and stroke. And those with early onset and severe preeclampsia have the highest risk of preterm delivery. And so this was a recently published study last year that basically looked at what do we discuss? We define premature heart attack as any woman having a heart attack before the age of 65. And what they found was that among women with premature heart attacks, 39% had a history of adverse pregnancy outcome. And the highest risk were those with preeclampsia, because the women who had preeclampsia presented 17 years after their preeclampsia episode. So they're presenting earlier in their 50s with heart attacks. Okay. And this is also associated with hardening of the artery. So preeclampsia, as I stated, is an independent risk factor for early onset hardening of the artery. So what we can do is a CAT scan to look for calcium buildup and hardening. And if you're in your 40s, really, there should not be any evidence of hardening of the arteries. And these individuals are presenting with elevated scores. So this is a scan that can be discussed with your healthcare team to get and to consider getting in your patients, because this can give us that earlier information and assessment that you may not be aware of, since it's a silent disease. But in this study, women with history of preeclampsia, they developed hardening of their arteries 5 years earlier from the age of 45 and onward compared to women without preeclampsia. So these are high-risk individuals. And then this is just a summary that if you've had preeclampsia, you're anywhere from 2 times more likely to develop cardiovascular disease and 4 times more likely to develop heart failure, gestational hypertension is at increased risk of developing high blood pressure, and gestational diabetes. So all of these conditions are associated with future risk for disease. So again, highlighting the importance of letting your patients know, getting them connected with the healthcare team, and to collect that important pregnancy history. And so, what we're learning, and we know, is that maternal health is a team sport. And so that 4th trimester, again, is critical. But a key part is knowing the signs. And you guys, know the signs, but a lot of time our patients don't. But if there's in the peripartum period, if there's development of chest pain, shortness of breath, swelling, rapid heart rate, fainting spell, high blood pressure, it's critical that they seek medical care. And for our highest risk patients, we do need to consider monitoring them longer in the hospital. For at least 72 hours. You want to monitor for signs of heart failure, can do some blood testing, where appropriate, place them on a heart monitor to make sure we're not missing abnormal heart rhythms. And then low threshold to get the cardiologist involved and do some more dedicated cardiac testing. And why is that? Well, blood pressure typically peaks postpartum days 3 and 6. And so it really is critical for these patients to have some sort of assessment and follow-up 3 to 7 days follow-up post-discharge. And then the blood pressure rapidly decreases over the first 3 weeks after delivery, with slower declines there afterwards. But again, as was mentioned earlier, it's important that we find ways to get our mothers in and birthing individuals within that 4th trimester and to have close assessment of their blood pressure. And, this is a critical time to assess, to counsel, and to treat. So you do want to assess for their blood pressure, physical exam, mental health, lactation, family planning, their various social determinants of health. And the counseling part is critical to assess lactation, their stress, fatigue, sleep, family planning, and of course, the critical time that I try to do in my practice is to discuss the long-term risks of these adverse pregnancy outcomes. And of course, treatment is critical. You do want to be aggressive about treating their risk factors. Long gone are the days, thankfully, where we're telling women, oh, it's just what's during pregnancy, preeclampsia, don't worry about it, because we know that's not the case. So you do need to monitor their blood pressure, treat it where it's appropriate, just to treat mental health disorders, refer to social services and to primary care, subspecialty care where appropriate, screen for diabetes and other risk factors. And in terms of the American Heart Association, it lists high blood pressure during pregnancy and preeclampsia as a major cardiovascular risk factor and recommends that women undergo some sort of cardiovascular screening within 3 months after giving birth. So it is a lofty goal because, again, the first 3 months, there's a lot to do and sort of competing interests with baby and mom. But we recognize in cardiology that this is a critical time for intervention and assessment, and we do recommend some sort of cardiovascular screening within the first 3 months. And during this time period, you're just going to make sure that you check their blood pressure moving forward, their cholesterol, blood sugar, and discuss the importance of a healthy weight. And again, adverse pregnancy outcomes, it serves as a window into your future cardiovascular risks. And so when there are pre-existing risk factors, obesity, high blood pressure, metabolic syndrome, which is abnormalities in their cholesterol, social determinants of health risk factors. And if they've had any of these adverse pregnancy outcomes, again, they're at higher future risk for heart disease, stroke, high blood pressure, diabetes, and heart failure. And so highlighting this important time for us to really incorporate this into our screening model, because part of the issue is that most of the traditional risk models that we use, like you can go online and do the Framingham risk assessment or the American College of Cardiology risk assessment for assessing your risk for the next 10 years. These individuals will automatically be low risk because of age. So we're gonna miss them. So if you're not asking their pregnancy history, you're going to undertreat. It's gonna falsely reassure you that their risk for over the next 10 years of a heart attack or stroke is low. So things that you can do is beyond assessing blood pressure, waist circumference, consider the calcium score as I mentioned, and doing some more advancing cholesterol panel testing. And critically important, just to inform these individuals that they're at high risk in the counseling. But again, with the fourth trimester, we know that 40% of patients do not attend a postpartum visit, with the lowest risk rates in the most disenfranchised patient. And as been discussed already, 53% of the maternal deaths occurs 7 to 365 days after delivery. And so things that we can do is include telemedicine that is available to our patients. And it just makes it so much easier for mom to be able to check her blood pressure at home while she attends to her newborn. And having a blood pressure machine at home, remote activity monitoring to make sure that they're staying active, the importance of behavioral health coaches. And again, funding is critical for these resources, but using it when you do have it. And the key is a multidisciplinary approach and ongoing screening. We do need that pass off to occur. And so at times it's just hard to capture mom, but sometimes if you go to urgent care or another setting, see an orthopedic doctor, but if there's some sort of blood pressure assessment somewhere, we do need to capture that, make sure it's part of the chart, and notify the mom and birthing individual to make sure that they get follow-up care. And what else can we do? Determine a long-term follow-up. So do they need to see cardiology, or will it just be the primary care provider? And discuss future pregnancies, for which, again, shared decision-making is a critical part of it. Some of our higher risk cardiac patients still want to proceed with getting pregnant. And so having these conversations and understand the risk and making the appropriate planning with a full multidisciplinary team can help the birthing individual achieve their personal goals. And of course, optimizing the risk. And so again, back to my patient, what was really concerning, again, her blood pressure was, correction to the slide, 177 over 106, not on any medications, even though having 4 high-risk pregnancies somehow went through the system without assessment. And her EKG was suggested that she had a heart attack. So what could we have done? And this is the call to action. So on an individual level, really focusing on the importance of the American Heart Association, the Life Essential 8, to do as many of those healthy habits as possible. And then from a healthcare professional level, treating stage 1 hypertension, right? So again, the guidelines have changed. Normal blood pressure is less than 120 over 80, but we consider high blood pressure now as diagnosed as 130 over 80 and above. So for those individuals, if they're coming to your office with a blood pressure of 139 over 92, these are high-risk individuals that need to be monitored closely, and probably in addition to lifestyle, starting medications, and not just say, oh, we'll just keep watching. We'll keep watching, because while we're watching, important things are happening from a cardiovascular health system. And where appropriate, refer for medical or surgical weight loss for obesity, and for what we consider the intermediate risk patients, consider calcium score. And then globally in a health system, providing more resources for remote blood pressure monitoring in a postpartum period, creating a postpartum transitional clinic that makes it easier. Could there be a model where both pediatrician and primary care provider and cardiology are in the same clinic, so all these things can happen all at once, and instead of expecting mom to make 3 different visits? And health coaching, group weight loss programs. And then on a community level, home visitation, community health worker programs, expanding WIC services, National Diabetes Prevention Program, and group exercise weight loss programs. Okay. And of course, from a legislative standpoint, providing more permanent funding so that the successful programs will continue to be able to serve our patients. And so in conclusion, there's rising incidence of heart disease during pregnancy. There is a strong need for cardiobstetrics to improve outcomes in our moderate or high-risk patients. And counseling and management of patients really should begin before conception, really during adolescence. And And of course, the critical need for long-term monitoring in individuals who had adverse pregnancy outcomes because there are higher risks. And we want to make sure that the baby has a healthy mom and a healthy parent around to be able to help them when they become pregnant. So we got to keep our families intact by making sure that moms are healthy, especially those who had an adverse pregnancy outcome. Yep. That's it.
Hello, good afternoon. So what I'm going to be discussing with you are more innovative community-based solutions to address maternal morbidity and mortality. So my name is Dr. Marilyn Berchie-Gialamas. I'm a family nurse practitioner specializing in maternal child health. I'm the postpartum nurse practitioner at Baltimore Healthy Start. I'm also the healthcare director with Trinity Wellness, which we contract with Baltimore Healthy Start. We do their nurse practitioner, nurse home visiting for all their postpartum clients. And I am also an assistant professor at Morgan State University, working with our Maternal Health Research Center. So I'm doing a lot, right? I'm also 2 weeks from delivering. So I'm kind of on the end of my pregnancy, but I absolutely had to be here because maternal health is just a passion of mine. So what we're going to review is community-based solutions to address maternal morbidity and mortality and their outcomes, and discuss our call to action for individual level, community, hospital level, and beyond. So what is our call to action? Our hospitals, our community providers, our private organizations that service any pregnant or postpartum woman really need to come together and collaborate to improve our maternal health outcomes. I mean, we are all here today to work together to decrease maternal mortality. As it's been said, collectively, all of our organizations together have all the resources, but we got to get together, right? We have to make sure that we're working on those warm handoffs and collaborating and partnering with each other. Like Tanae was saying earlier, not one organization can do it all. We have to work with each other to meet all of our clients' needs. And then as we go through it even more, like Dr. Gina was saying, when we think about all of our providers, not just OBGYNs, but our mental health providers, our social workers, our chiropractors, our physical therapists, our dentists. I was just looking for a dentist that will help a pregnant woman with a chipped tooth, right? It's been too long. And honestly, I couldn't find a dentist. My OB said it was okay, but the dentist didn't want to do it. So, and that, I mean, to me, I'm just like, that's crazy. But making sure that we're all together and working together for the best outcomes for our mothers and our children. And then, of course, we're also thinking about our policymakers, our government officials, to provide the funding and the support that we need to do the work. So some of these what we call innovative community solutions, we really need to meet our women where they are, meet our birthing persons where they are. I think one of the providers said we need to get our butt out of the office. Yes. And this is what we do in Baltimore Healthy Start. We really need to promote health and identify how these social determinants of health and structural determinants of health are affecting our maternal health outcomes. And yeah, we have to meet the woman where she is. I do a lot of the postpartum home visiting. And I'm not always meeting them at their home. I've met a woman at her job to give her, you know, her blood pressure cuff. I've met someone at the market. I've met someone, you know, wherever they are. If you're in Baltimore, I'll find you. Because I mean, these are women that have, you know, they have lives, they have children, they have, you know, things going on. And really we need to kind of get out of our silos in order to reach them, especially our high risk populations. We're also going to talk about supporting the family as a whole, using the 2-gen model, where we're not just focusing on the mom, but we're focusing on the children, the father, and anybody in that family circle, whether it's the auntie, the uncle, whoever is there. I know we have some clients that live in group homes, and I've talked to the people that that assist them and things like that. So anyone in that, you know, village that's helping that family and helping that mother and the child. And then we need to provide continuous individual and group support. I always say I'm a postpartum nurse practitioner. I love postpartum women. The biggest thing that I've seen, this is my second baby in 2 years. And after my first one last year, it's like, it's so exciting when you're pregnant. It's so exciting. Everyone's there. Then you have the baby and it's like, who are you? Where's the baby? Like walking into rooms, where's the baby? Like, wait, what about me? So we need to provide that continuous support, group support. And we'll talk about some of the programs that we do at Baltimore Healthy Start. And one of the programs that I have initiated to help provide postpartum care, because once you have a child, you are forever postpartum, right? It's not just the 6 months or the 6 weeks or the 12 months. You're postpartum 2 years later. I'm postpartum and pregnant, so we have to think about that as well. And then collaboration, I'm going to beat that in my whole presentation. We need to collaborate. We all need to just bring it all together and work together for the greater good of our mothers and babies. So as I said, I'm the postpartum nurse practitioner with Baltimore Healthy Start, and we do a lot of amazing programs here to reach our clients and to make sure they get the care that they need. One thing that we utilize is that two-generation approach. And that program is designed to use two-generation strategy to support and empower families, where the whole family, we provide wraparound services, which is intensive case management, supplemental support services for the adult and children. So what we're looking at is making sure the young children have access to safe care, effective academic supports, that the family as a whole have access to safe and affordable housing, right? So some of these social determinants of health that we talked about, that the families have access to preventative as well as ongoing mental health support to overcome trauma, addiction, substance misuse, that the adults are able to secure and retain jobs, but to sustain jobs that provide a living wage, which is really hard right now. And then, of course, we are looking at making sure that the adults are empowered and equipped to advocate for themselves. So Baltimore Healthy Start, we do this two-gen approach. There's also some other organizations that we partner with, like the Center for Urban Families, that as well use this two-generation approach. So a little bit more of what I talked about, meeting the woman where they are. So the goals are, of course, we want to enhance the mother's health. We want to prevent infant mortality, and we want to eliminate the health disparities. So we provide home care services. We have community health workers, case managers, doulas, nurse practitioner, nurses. We partner with mental health organizations. And as I said, we meet the woman when they are. We want to remove some of the social determinants of health, like access to care, and not having childcare to go to your appointment or what have you. And like I said, meeting them either at their house or wherever they may be to make sure that they get the services they need. So we do clinical care services. So I do for all our postpartum moms. We meet with them immediately after delivery, right? So not just 6 weeks, but within 2 weeks, within a month, monthly until they're 18 months postpartum. Every woman in our program, which they service over about 1,000 women a year, they all get blood pressure cuffs, right? Not just women who are at risk for high blood pressure, but everyone should be able to take their blood pressure. And we don't know when the preeclampsia or when their blood pressure is going to start elevating. I've had several clients where they had a great pregnancy, blood pressure was beautiful. That 2-week home visit is when we start seeing the blood pressure elevating, and they got readmitted to the hospital and then treated for it. So if we didn't give them the blood pressure cuff ahead of time and we thought they were at low risk, we would never have caught them. And that's happened too many times that I can think of. Other things we discuss are those maternal warning signs. We educate them, the screenings and everything like that. The education, I would say, is very helpful, especially in this community portion, because it's so funny, actually. I was just cleaning out my daughter's stuff to get ready for my new baby in a couple weeks, and I found my discharge paperwork, and I'm like, oh, a year and a half later, I'm looking at this. Like, nobody reads that. So honestly, having our community health workers and our nurses come to their house and discuss it with them when they're not in the fog of just delivering. They might still be in a fog from not sleeping, but it really does help solidify the education that was tried to give to them during delivery, but there was too much going on. And then also doing the screenings while we're there. I've seen doing home visiting, a lot of we'll tell you what the maternal warning signs are, but during pregnancy, a lot of the abnormal things like headaches and swelling and things like that, which is now a warning sign, we've been told for so long, oh, that's normal. Oh, you're gonna get a headache. Oh, your feet are swollen, that's fine. Now we're postpartum and we're thinking, oh, this is normal. So having that nurse practitioner, nurse, community health worker come to their house and assess them and say, that's not quite normal. We really need to talk to your provider. I've done care collaboration when I've spoke to providers like, oh yeah, well, we already talked to her. I'm like, no, you need to see her now. I'm sorry. I'm here in her house. I'm evaluating her. I'm doing her blood pressure. This is not normal. She needs to be seen immediately. So that's a big thing where we need to get out of our offices and really hear what the patient is saying, and listening to our patients and their concerns. And then we also promote immunizations. We do intimate partner violence screening. We provide access to transportation assistance, emergency food assistance. And we also talk about our housing assistance, and I'll talk about that as well. Already talked about the maternal warning signs, education, screening. So as I said, all of our clients get blood pressure cuffs, and we do monitor them very frequently with their blood pressures. We also do blood glucose screenings if they did, have gestational diabetes or were borderline or what have you. We do our mental health screenings. That's a big thing that I'm a proponent of. I did my doctorate project on postpartum depression screening and referral. So we do our postpartum screenings, like we said, intimate partner violence and things like that. And we go over the maternal warning signs each and every time until they're like in the clear. One of the partnerships that Baltimore Healthy Start has with Total Health Care, correct, is through dyad care, which I love this program. And that is when the mother and the infant get seen at the same clinic, same day, same time, right? So we are trying to eliminate some of these access to care issues. We talked about how, a lot of times we'll take the infant to their pediatrician, but us as the provider, as the caring mother, we don't always think about ourselves. So this is a great program into where they're being seen and the mother is being seen too. Not just getting, her postpartum depression screening, but her full postpartum exam. She's gets seen by the nurse practitioner, and she is able to schedule her visits with the baby. So we're able to access a lot of more women there. And this program has been implemented for a good amount of time, and we've seen over 400 women in the dyad care program. So I really, really hope to see that this does get expanded on as well. So we have our doula care program, and that is where we are training community-based doulas to increase the availability of doulas to those most affected for mothers and infants. And so I know Tania over here, she was an integral part of our doula care program. And I believe they're all trained and everyone's getting their hours. And the women in our program will be able to access their doula care services free of charge. And that was funded by the HRSA community-based doula supplement as well. We also have our housing university. That's another great program that provides assistance to pregnant and postpartum tenants over the year to at least 40 pregnant and postpartum women. They go to our housing university. They're in the housing university for about 2 years. And We teach them about, being a tenant. We assist them with like down payments for their deposits for the wherever they may be living. We assist with moving help and things like that. So it's another program where we can try to remove some of those barriers, some of those social determinants of health barriers. So we talk about the different classes, the wellness and family engagement classes that we do for our Women in Baltimore Healthy Start. Belly Buddies is one of our unique programs that started at Baltimore Healthy Start. And what we do is that it's a unique program where pregnant women with similar delivery dates meet to receive prenatal care, information to reduce stress. They get to share experiences, create bonds and sisterhood while getting valuable information. As I said, it was developed right here at Baltimore Healthy Start. It's an 8-week program. They come about 2 times a week. They get childbirth education, yoga, and stress relief. We talk about nutrition and cooking demos, crocheting, scrapbooking. We talk about parenting classes. And at the end, they have this beautiful blessing way ceremony as well. And these women can, after the Belly Buddies program, they also can continue into some of our other postpartum classes as well. And people in this program too will get connected with doula care services. So this is one of the amazing programs that we have at Baltimore Healthy Start. It was very innovative, and that got started right here at our organization. We provide our breastfeeding classes. I know Tanika's here as well. She's one of our IBCLCs that does teach our breastfeeding classes. As you can see here, all the amazing pictures here. We have a bunch of women that come to our breastfeeding classes and get the support and help they need, whether they're exclusively breastfeeding, pumping, doing a little bit of both. We're just trying to make sure that it's not as a stressful process as sometimes it can be. We have Circle of Security parenting classes, which is another 8-week session for mothers and fathers. And for most of our programs, there's always childcare available. That sometimes can be an issue. So we do have childcare at a nice little childcare center at our Baltimore Healthy Start location. And usually we provide dinner, lunch, depending on when it is. And our clients usually get a stipend for our gift card for attending some of our programs as well. So those are just other ways to get them more involved. We have our fatherhood program. I love our fatherhood program because it's a way that we can get the men involved to be active participants and to assist them. As we said, it's stressful as well, maybe not as physically, but mentally during the pregnancy and postpartum period. And the fathers get together and they have their meetings and discussions. I think I was in one because I talked about blood pressure and stuff and they kicked me out so they could talk together. But they have a good, bond with the men that are there. And as Dr. Baptiste Roberts was saying, having a daddy doula program, we really need to make sure that we are involving the fathers and the men in everything that we're doing, because we don't want to just focus on the mother. We need a focus of the family as a whole. Then we also have parent leadership classes as well. So the Mama Circle is one of the groups that I just started as the director of Trinity Wellness. I started it out in Howard County. That's where I was born and bred. And this is a postpartum group similar to Belly Buddies, but we're focusing on postpartum moms. As I said, unfortunately, we get forgotten. As soon as the baby's gone, it's just like, and it's a crazy time period because you're adjusting, your whole life is adjusting. You have this new baby, it's stressful. The mental health aspect of it is another thing. And a lot of times we're looking for a village and the village is not there, or they want you to pay for the village. And we don't have that money to pay for a village right now. So it's focused on postpartum moms. We talk about the physical, mental, and spiritual wellness. Typically it's about 3 to 5 groups. We're trying to make it something that it's monthly. As I said, I started it out in Howard County. We did it for the community there. We also were in Wild Lake High School in their teen parent child care program. And that was wonderful working with the high schoolers there. We did about 3 sessions with them and they absolutely loved it. But we talk about mental health. We talk about physical health. We talk about family. We talk about, creating healthy relationships in our family. We talk about creating boundaries and things like that. And then we do a lot of mindfulness and yoga, meditation. We've done nutrition classes and healthy eating. We do some exercise classes. We did belly dancing last time. That was just a couple weeks ago. We did it at Baltimore Healthy Start as well. And I had a nice big belly to dance with. But this is kind of one of my babies. Actually, a picture on the end was from a few weeks ago at Baltimore Healthy Start. And we did our mindfulness class there. And that's when the woman was like, I would love to do this once a month. Like, can we just come here once a month? Because the kids were downstairs in the room and we were upstairs, talking about our mental health and just talking to each other and, just getting the education that we needed and bonding. And it was such a beautiful program. So as I discussed, our biggest thing is collaboration, right? So working together, I know after this, I'm gonna try to meet with some of the providers and people here, get cards and information, because we need to know, we need to make sure that we can collaborate with each other. We can make the referrals that we need. If we're doing all these screenings, we have to make sure that now we're referring them, right? If we screen them for substance use, if we screen them for postpartum depression or hypertensive disorders or gestational diabetes, okay, what's the next step? We need to do these warm handoffs and not just hand them a phone number because they're not going to make all these phone calls. We do a lot of care collaborations. I know in my home visiting portions, I've been in a house for an hour long. Mr. Postpartum visit. So we scheduled the postpartum visit, we scheduled her mental health visit, and we scheduled a visit for the baby. And these are all things that I'm on the phone with her, assisting her with that as well. But we also need those resources and other organizations to know who can I go to? Because I called and like, oh, well, she missed her visit, so she won't be able to be seen for another couple months. Well, that's not what we want to hear, especially someone who did unfortunately miss her visit. She's not going to go to that visit in a couple of months. So having those good partnerships with community organizations, I know we work well with Transformation Health for some of our mental health clients. And they do a lot of telemedicine healthcare or some home visiting as well. So having that warm handoff and having a good collaborative partnership will assist us in getting the women and the families the care they need when they need it. So I just wanted to touch base on this. As I said, I do work with Dr. Baptiste Roberts and Dr. Yvonne Bronner at Morgan State University. I'm one of the co-investigators on the Maternal Health Research Center. As she discussed earlier, we have a coordinating center that Dr. Bronner heads, and I'm a co-investigator on the research center. And our main goals is to develop community-based solutions to address the disparities and advance health equity in collaboration with targeted communities. So that's our biggest thing that we're focusing on. We don't want to just do the research and walk away. We want to make sure that our research makes a difference. And we're trying to create these pilot community-informed interventions to improve maternal health outcomes and to evaluate these outcomes to make sure that they're effective and disseminate these recommendations to the community. So as we're doing this, you'll be hearing back from us from some of these community-based solutions to see, what were the outcomes? Were they effective? So hopefully other organizations can replicate it and we're able to work together to reach more families. And so outside of the 2 research centers, I also am a principal investigator on a CMS grant for doula care. So we talked about doula care a lot today. So the Centers for Medicaid and Medicare Services, they cover doula care. Yay. I say it like that because the research is showing it's there, it's covered, reimbursement isn't the best, access to it isn't the best, and our research is showing that women aren't accessing it. So for our qualitative research, we really are trying to identify the factors that are the barriers and the things that are facilitating the use of doulas, because we want to inform CMS. Like, this is huge that they're covering doula care. The research shows that doula care improves birth outcomes. It decreases C-section rates, especially for women of color. We have reimbursement, but we need it to work now. So we have started our 3 focus groups. We actually have a focus group this evening. As I leave here, I'm going to our focus group. So we can figure out a way to make this program more effective to reach the women that are truly in need. And so, yes, it was funded directly from CMS. So we're hoping that we can inform them on that information in order to improve the access to doula care. So that's it. Hopefully one of these community-based solutions can be helpful to you. Yes, any questions? And for Dr. Jean as well.
Hello. Hi. I'm over here. I don't know if you can see me. Hi, I'm Lauren. I'm a postpartum doula and I co-chair Postpartum Support International's Maryland chapter. We do have a doula group. The Doula Alliance of Maryland is growing and looking for doulas across the state. We have a Google group already with about 75 doulas in it, and we did conduct a bit of a similar study with focus groups last year. So we wanted everyone to know about it who are doulas, working with doulas. We're actively advocating with Medicaid and on the program to help with the living wage and all the administrative barriers that exist. I don't qualify as a postpartum doula because to help Medicaid users because I am not a birth doula. So there are things like that that impede us to help people that we meet on the ground in the community. So I would love to connect with anybody interested.
Absolutely.
I was wondering both doctors, would it benefit moms to have like one OB provider as opposed to many different OB providers when they're receiving their postpartum care? Would that benefit them for continuity of care and other benefits?
I feel like it depends on the woman. Unfortunately, so when it comes to finding the best provider, especially sometimes for women of color, it takes some time to actually find the provider that's best for you. And especially if you have like Medicaid or something like that, you're stuck with that one practice. So at least at that one practice, you can see several different providers. There might be one that you might not mesh with, but there might be another that you may, do really well with. I know even personally, at my OB provider, there was one that was like, yeah, I can't work with her. But the other one that I saw, I worked really well with. They actually listened to my care and concerns. And that's a big thing that we're hearing and seeing is that our women aren't being heard. So I like the fact that you can see different providers. But for continuity of care, sometimes that is the best, to have someone that's going to follow you through. But unfortunately, I mean, when you deliver, you never know the day and the time unless it's a scheduled C-section, and you don't know who's good at delivery. So you could see someone the entire time, but then deliver with somebody else. So I can see where you're coming from. But I know on our end, when I'm working with women, if they have any issues with the provider and we're trying to find someone else, at least we can find someone else in the same practice.
Because the moms they didn't know that they could probably get one provider and say, I go to the,
Yeah.
I don't know who this doctor is. I see this one and that one and that's a barrier.
Yeah,
I think.
yeah, it can be.
And just another question, with the telemedicine, is it available to all moms that have preeclampsia or eclampsia or hypertension? Is that, the automatic blood pressure, they can take it and read it at the telemedicine office? Is that available to all mothers?
So it depends on the system and what they're using. So at MedStar Health, one of the things they use is baby scripts. So it really will depend on the provider and what resources are available, but it is critical that that ongoing continuous monitoring of blood pressure is done for better outcomes.
especially postpartum. And then
especially postpartum.
She wanted to know why do the doctors prescribe aspirin for preeclamptic moms?
Oh, that's a great question. So I didn't include the aspirin in my talk, but research has shown that by taking aspirin starting the second trimester, that can reduce the risk for preterm preeclampsia by about 60%. So obviously, it doesn't completely solve the issue in terms of preeclampsia, especially in a postpartum period, because it still will occur. But if we can at least get moms to term, that leads to better outcomes for both mom and baby. So that's been found to be effective. And so they have different ways of sort of assigning whether or not you have one major risk factor, for which high blood pressure, for example, is one major risk factor, and then minor risk factors. And one of the important things to know is that being a Black woman is considered a minor risk factor, and not because of any biology, but again, what's been discussed this morning in terms of the ongoing chronic stressors and social determinants of health.